Ini adalah amanah. Melindungi pekerja merupakan panggilan yang mulia untuk kami.
Bukan hanya tentang hari ini, tetapi tentang perjuangan menjalankan roda kehidupan.
Karena kami ingin terus memberikan apa yang menjadi mimpi besar anak-anak kami.
Kerja keras untuk keluarga demi masa depan yang bebas cemas.
Terima kasih karena telah melindungi kami sebagai tulang punggung keluarga.
Amanah besar yang diberikan kepada BPJS Ketenagakerjaan mendorong kami terus berinovasi. Apapun resikonya,
Kecelakaan kerja di saat jauh dari keluarga, kehilangan mata pencarian,
Hari tua yang tak berdaya.
Bahkan kehilangan nyawa sekalipun.
kami berdiri di sini untuk membawa arti bagi keluarga. Negara hadir melalui BPJS Ketenagakerjaan untuk mewujudkannya. Perlindungan pekerja sejahtera.
Okay, ladies and gentlemen, we will go to the next agenda for our first speaker. Today, we will have a topic about the topic title is Disaster Nursing and Health Security, with considering the elderly as the biggest part of the population. And the speaker is Professor Sakiko Kanbara from Kochi University, Japan. And the moderator is Miss Stephanie Melia Escape Nurse, MNS. She is a lecturer at Nursing Faculty of Immanuel Institute of Health. Okay, for Miss Stephanie Melia, please welcome and please all the time is yours.
Thank you for Miss Argini, the MC. Good morning, ladies and gentlemen. Please introduce myself. My name is Stephanie. I'm the moderator for the second session in this conference. Ladies and gentlemen, good morning and welcome to Immanuel Institute of Health Third International Conference with the theme Promote Healthy Behaviors and Achieve Health Equity across all life stages. We are honored to have with us today distinguished speakers, Professor Sakiko Kanbara from Kochi University, Japan. Good morning, Professor.
Pagi.
Pagi. Professor can speak a little bit Bahasa. Okay. Our topic today is disaster nursing and health security with considering the elderly as the biggest part of the populations. Ladies and gentlemen, before we dive into the topic, let me provide you with a brief overview of Professor Sakiko Kanbara's impressive background. Okay, first of all, in 2007, Professor graduated the PhD in Public Health and International Health, Okayama University, Graduate School of Medicine, Dentistry, and Pharmaceutical Science. And she is researcher of University of Kyoto and more, and focusing in disaster nursing and global health. She had 16 years of experience of academic research, education and practice on implementation oriented in disaster nursing. She's a founder of EpiNurse, and in 2017, got a risk award from United Nations Office for Disaster Risk Reductions. In 2022, she's a professor in Kobe City College of University, and currently serves as a committee member Japan Academic Network of Disaster Reductions, and both Japan Society of Disaster Nursing, and a member of Japan Science Council. Professor, for this presentation is around 30 minutes, and I will give you a signal when there are only 5 minutes remaining. And for all participants, if you have any questions, please feel free to write them first at the chat. At the end of the presentation, there will be a discussion and question and answer session. And now, without further ado, I present to you Professor Sakiko Kanbara, who will enlighten us on disaster nursing and health security with considering the elderly as the biggest part of the population. Professor, time is yours.
Thank you very much for inviting me to this conference. Nice to meet you, everyone. My name is Sakiko Kanbara from Kobe City College of Nursing. So today, I would like to talk about disaster nursing and health security for elderly, especially for elderly people. Yeah, because in Japan, very, very aging society and yeah, very disaster prone area. So, and nowadays we much more think about climate change and another risk also. So today topic is focus much more disaster nursing and technology users utility for especially for GIS and some kind of big data or open data, and because disaster nursing is based on many disciplines, including epidemiology, public health, and care, and kind of community empowerment and focus much more gender sensitive or vulnerable people. And so today I'll talk 30 minutes about my experience and example of my works. Okay, we'll share my screen. Okay, yeah. So title is Disaster Nursing and Health Security with considering the elderly as the biggest part of the population now in Japan. Yes, this is my profile already. The
Excuse me,
introduced.
Professor. I'm sorry. The slide is haven't open this. This one. Okay. Thank you.
you. Thank you for letting me know. So this is my profile. Yeah, actually academic profile, you already talk about that. Yeah, but my profile is personally born in Okayama and working in Kobe as, yeah, at the time, 30 years ago, Hanshin Awaji earthquake, 1995. At that time, I was a university student. So I don't know about nursing and what is care and what is disaster risk reduction. But anyway, I live in Kobe. So then I experience and work as a epidemiologist, public health nursing, and many and many and collaborate with researcher in Indonesia. During this time, as you know, 20 years ago, Sumatra Aceh tsunami earthquake occurred. Yeah, at that time I worked with Indonesian Nursing Association, Ahiryani Sensei, and yeah, Ahiryani Sensei, and after that, 10 years ago, Nepal Gurukha quake. At the time, I collaborated with Tarapokare and also Nepali Nursing Association. Yeah, this mentor is for me for disaster nursing. So I learn many from them. Yeah, of course, as you know, Florence Nightingale worked on Crimean War more than 100 years ago. This kind of activity and prevention works is, I think, connected to disaster nursing. So I'd like to talk my experience, but from this kind of experience, you can and let us discuss what kind of nursing action or health caregiver action is required in future. Yeah. Yeah, so also now already published this 30 years disaster nursing and connected, especially not to acute phase and emergency medicine, but primary health care is very important. Okay, in, someone raise their hands. Okay, ですか? Yeah, okay, it's okay. Okay. Yeah, so I would like to discuss why disaster nursing. Yeah, now, yeah, because Great Hanshin Awashi earthquake 30 years, Hanshin and Aceh tsunami and Nepal Gokul quake and everywhere in the world, disaster occurred everywhere. Yes, so first of all, I'd like to identify what is disaster nursing. Disaster nursing is like this is a definition of disaster nursing. It involves a systematic, adaptable application of nursing discipline knowledge and skill payment to disaster. That encompasses the creation of initiatives aimed at reducing the harm and the risk to life and health and result from disaster, and in collaborate with various specialized fields. So this is transdisciplinary approach, including community and people and many researchers also and stakeholders. Yeah, in other hand, I launch Epinurse. What is Epinurse? Epinurse is not disaster nursing as I work for disaster nursing as disaster nursing research scientist. And Epinurse is the nursing practitioner here. Yeah, with aim of reducing health risk associated with climate change and natural disasters, that we Epinurse implement and develop initiative, not research, but initiative based on care science to create safe social mechanism and environments in Japan and overseas. That means much more practical work and community-based approach. Yes. So our agenda now planetary boundary and climate change and many risks come. So we should work for much more human-centered and not only communicable disease, non-communicable disease, more we need understanding risk surround the world and planet. So there is impact on human health through the disaster, abnormal weather, and including indirectly through conflict and poverty and many things. So there is an interdependent relationship between global environment and humanity. So feel many far, but very close. So there are we are exposed to risk caused by global environment and approach our own local and health issue and global environmental issue. This combination can reduce and resolve the damage and impact caused by disaster and many risks. So, and we want to leave behind a well-being society for the next generation, near future, and where each person can live their own lives. And from planetary health perspective, planetary health perspective is a little bit different from global health perspective. Global, the world, public health, primary health care and public health and global health much more social economic issue affect, but planetary health, we should think more ecological effect also. So we should protect the health of people and the planet to realize sustainable. What is sustainable? Disaster nursing, we have to discuss. Yes. So our work, so disaster nursing and initiative of disaster nursing is now currently we have developed our project in Japan and other country, especially for East Asian country. Yeah, because nursing is not only disaster nursing, but nursing itself and health caregiver and health issue is not the just fact or risk, but also their own culture. So how we work and how to care and people can live on in own culture, including this kind of planetary health. So need is not build for recovery, or for example, for the RR or recovery, not only the build very strong or resilient house, but also need training, leader human resources, and how make the capacity building. If we do as disaster nursing or capacity building and community empowerment people, we can make resilient community and city. So this is the theoretical explanation model my disaster nursing and planetary health. Yeah, you may know about this purple circle. This is you may find in social determinant of health on global health. Yeah, social determinant of health. I mean, more than 30 years, not 30 years, 20 years ago. Yeah, Mark Marmot and many social epidemiologists discuss about this. Yeah, this cycle means the human-centered, but many social determinants of health affect as health risk. Not this not only inside their own lives, but also in the real life factor. So, for example, exercise or cooking or many things. This is related to non-communicable disease also. Yeah, and then living working condition, including occupational health and for communicable disease, much more environmental health also. Yeah, then nowadays and public health, I think much more global health, think much more general socio-economic and cultural and environmental condition, and for planetary health and climate change or disaster nursing, we need to think much more ecological issue. So we make this gradient. So we care family and individual and community, but think much more global issue. Yeah, this is left one is basic social determinant of health model. You already know about this. This is basic one. Then right side, if nursing diploma may know, this is raining sunrise model, cross cultural model. Yeah. So this is a Leininger model. Yeah, more than 50 years ago, they think, yeah, surrounding human health. This is culture. And what is cultural factor? They identify and understand the risk and understand the culture and how to make the care is very important. So this is generic care and nursing practice and also professional care and cure practice, that is nursing. So, and nowadays, this model is disaster risk reduction or climate change. Many scientists, apart from the nursing science, they really want to know and want to utilize this model. So another transdisciplinary works especially for not natural science scientists, but also humanitarian issue and humanity people want to know about this model more. So, and I would explain about this model with another discipline people and collaborate. Yes. So, and also easy to community people to understand because that is culture. Yeah, then this is another transdisciplinary works. Yeah, this is from the another discipline. Disaster risk reduction concept, disaster risk reduction works. They understand hazard, but risk is not only hazard. If hazard escape from hazard, we have no disaster event. Yeah, and if protect people and people's life and maintain health, we can reduce the disaster risk because we can care vulnerability of people. And living our environment. This is the formula of disaster risk reduction. This is capacity building and including people empowerment and maintain their living environment. This is, we need all the RR phase, preparedness phase, and even acute phase, and recovery phase, and much more sustainable as city development. So as a result, what is nursing action? Yeah, that's just example. Yeah, for example, acute phase, that means that is result as first aid of mental health and mental health care, secure food and toilet. This is because of this care of disaster risk reduction every day. So let us discuss what is care with disaster risk reduction every day for Indian Java people or the tsunami prone area or volcanic eruption area, and depend on the community and national issue, national country, and very different and different way. And acute phase, first aid also depend on the culture and depend on the culture and national health service. So this kind of adaptation is very important. Yeah, but based on that, and Florence Nightingale works and theory can adapt water hygiene, wash issue, and then care and water, clean air, something like that. Yeah, and in other hand, as epidemiologist, not only hospital, but also we care and need epidemiological data or in community. So what is the not is what is the community and who is the community, not only where is community. So, and we need much more, if at the time of disaster, just to calculate in the hospital, they say sometimes no casualty, no patient, because they cannot go to hospital. So we should go community and at first. So, and not to calculate the count, not to count of disease or not disease, but because they go to a mobile clinic already. So anyway, need who is community, how many is community at the time, and what kind of, what's vulnerability and what their human basic needs we calculate. So, and after that, we every day we care and how to reduce the risk. We think about that. And if we utilize the epidemiological works and you, for example, mapping, not only, yeah, nowadays DRR mapping is only building or geographical issue, but nursing care and health probably helps people. Not only the number of people, but also how damage and how people can rebuild and how they can work on. And this is Nepal at the time of Nepal Golkar earthquake. Yeah, we can use GIS, not only paper map, but also we use GIS, including web map. And also we have a smartphone, and community people also have smartphone, and we can connect by 3G. So, and yeah, at the time in 2015, actually 2G, so very difficult to send the a photo, but nowadays we can send the photo. So once we uh, take the photo and you are safe or work, how damage. Yeah, if call the phone, cannot connect sometimes. So, but they take the photo and send the photo, and they empath and they realize and they can understand what is required in now. And we can continue and we can continue to prepare and provide tomorrow or after 3 years, not 3 days, what is needed? Maybe what community people need or how damage occurred and how to repair, we can predict and care and more proactively. So, this transdisciplinary nursing in disaster risk reduction, mapping and human-centered mapping and human based on epidemiology, public health, and disaster nursing and nursing science, and collaborate with another cultural anthropology, informatics, geography. Many people collaboration, we can develop much more proactive disaster nursing, I thought. Yes. In other hand, this is work of other disaster nursing relief and initiative, but now this is a coincidence. 2018, my mindset change. Flood in Western Japan in my hometown that occurred. At the time, I was on maternity leave. So I am off of my work. So no textbook and no team at the time. But so I have to work with my family and my old friends. And that's real using traditional knowledge and community empowerment, I have to implement by as a survivor. Yeah. So at that time I realized, oh, my early warning system and disaster relief dispatch system is incorrect. Yeah, because they are too late. So community people have to not last 1 mile, but as first 1 mile, community people should work and with people and community. So, and they have not only data and disaster knowledge, but also most important leading knowledge is sense of urgency and intuition. So that should collaborate with community people, I realize. And my grandmother know many things about that. So where is well and where is people and where is community and how to care. And in other hand, because I'm a dispatch nurse, so I work in this shelter like this. I realize, oh, this is the like yeah, I experience not to disaster relief provider, but as a survivor, I have to work and coordinate the community and then I realized, yeah, usually dispatched nurse and from outside, they work daytime and go back nighttime. But the critical issue in aging country and people many people have dementia, need medication. And anyway, the social adaptation is very, very difficult. And yeah, night time, many people feel worse, become worse and worse. So I realize need not daytime because many dispatch team, but nighttime community people and community nurse, local nurse, many work. So I have to, should connect to many, another, my friend nurse or community nurse nearby the affected area. I correct and ask them to please come in the night and communicate and arrange. And in other hand, in my home, my mother, oh, need not a water provider. Yeah, because my house have well. So yeah, independently they can work because my mother and my house have well and um, uh, charcoal independent and cooking system also. So need not gas or electricity. So they can all work. My mother's shelter, yeah, my mother's house become shelter, and many people come and independently can work for that. Yeah, in other hand, yeah, because of this community empowerment, yeah, many people go out, yeah, by national system, the national relief system, government relief system, many people uh, go out to uh, out from the area because need to move safe area and many evacuation shelter. But I realize, oh, people come back soon to my own home. Yeah, so that's very natural. So yeah, and we realize and the insight of local caregiver, they are main good informant and they are very good monitor. And EPI and community people can work as a caregiver, directory caregiver. So we should help not directly to community people, but also we should care or caregiver, and so that a local caregiver can work very more flexibly. So this kind of logistic and care of caregiver or logistic support is much more important and collect information from local insight. So, and make this map and local map, own map, because with family. Yeah, not geographer. With family, I can make the mapping and this kind of like using open data. So we realize, oh, temporary toilet, no one knows. But local people, oh, this is temporary toilet. Many people can, volunteer come and put the temporary toilet. So and we find the temporary toilet. So make the temporary toilet mapping, for example. And this is emerging. Appear, imagine appear that, for example, mobile clinic appear and mobile bank appear. So I will local people map and let them know each other. In the other hand, afterwards, I realized using the people flow data. People, if my mobile phone collaborate with Yahoo company, I use the people flow data. I realize no people not only go to shelter, they government estimate and expect. People go, including greenhouse, village hall, many everywhere they go, and no care because government no only identified shelter. So we use this kind of disaggregate data. Where is community? Who is community? We visualize. Yeah, and also make the another geographic mapping using the application and spatial vulnerability assessment also using open data and collecting community people collecting data. So as a result, now, anyway, this is just one example, the theory and example. So what is that? So work is advanced science and global public good, not medical evidence, but global public good. Yeah, disaster nursing. Yeah, not intra disciplinary and collaborate. Just collaborate is interdisciplinary. Now we call interdisciplinary, but transdisciplinary is one group, one team, one disciplinary as for disaster risk reduction or future vision. Yeah. So, and for that, and health, for example, this is a disaster nursing for health equity, inequity. So I make the book, and yeah, in US, yeah, health equity is a critical issue, and at the time, health inequity occurred. So, and I make and contribute. Yeah, disaster nursing in Asian country as a culture is very can contribute at the time of COVID situation and disaster situation. This kind of cultural nursing, cultural adaptive nursing, and using epidemiology and transdisciplinary approach is very adaptable for another country using the theory and technology. So let us work as global civic pride. Yeah, not only our country, and let us learn each other in laboratory and online like this today. Yeah, and let us go to community together and each other country and every country and community. Let's understand the community empowerment and community works. Yeah, and after that, in future, nowadays we make this combining emerging technique with traditional knowledge for effective solution. Yeah, this you visualize in the hazard map. We make safe, where safe place and where basic human needs is required and what is hazard. For example, this is hazard and this is barrier, need police, not only medical team. Yeah, for example, human trafficking or gender sensitive issue. So nowadays, metaverse or 3D model or virtual technology can much more immersive understanding risk, much more effective. Yeah, so nowadays we make creative, much more transformative development. We contribute now. Yeah, yeah, this is just example. Yeah, this is nowadays, this is virtual one. Yeah, and then utilize traditional work and discuss and visualize and cross the border and cross the generation and discuss new situation and develop and visualize the future society. So now the global issue and the local action, not only DRR. Nowadays, self-care is much more important. DX society, lifestyle change, and remote consultation also available. So how to mixture of this for DRR, or not only DRR, but healthcare and citizen and much more sustainable resilient community and sustainable business, disaster management, and or climate change. This kind of global change issue, yeah, DRR connect, disaster nursing connect, of course, public health connect. So, yeah, maybe, and this is just content, so, and global issue. So, transdisciplinary approach and national community approach is, and one global society, let us discuss and how to make the new discipline or works. So we call now Transform Global Learning. This is on November 29 and until December 1. So we visualize, make the event. Yeah, now abstract call. So calling abstract now. So please save the date, save the money. Please come to Japan to discuss what is disaster nursing and how to secure. And yeah, so the concept rethinking disaster nursing. And now this is open governance. This is primary health care to social innovation for primary health. So usually usually academic discussion or event usually close on only in Japan. But now my this work, yeah, in evidence for sharing evidence as main session in our coverage, and to collaborate with community. So make the much more open session we make, and also provide online. Yeah, this is one of the transformation of academic collaboration now. So thank you very much for listening, and let us rethinking disaster nursing in a changing risk environment. That's my topics, disaster nursing and for global elderly community. Thank you very much.
Okay. Thank you, Professor Sakiko Kanbara, for giving us. This is when I read the presentation and I heard from you. Wow, it's like really changing knowledge for me, because as we know that Indonesia itself is a supermarket of disaster. They say it excluded the ice or winter. And next we will continue to discussions and question, and if the audience have any questions regarding the disaster nursing in changing risk environment. So there are two questions, Professor. Hopefully you can address the questions. The first of all is from Miss Widyadari from Immanuel Institute of Health. Maybe I will write it first. And please, Miss Widyadari.
Okay. Okay. Yeah. Does my voice sound clearly?
Your
Okay.
voice is clearly.
Okay. Thank you for your explanation, Mrs. Sakiko, PhD. I'm Widya Dari. I'm Immanuel Institute of Health lecturer. Yeah. As we know, Indonesia is categories. Okay. Yeah. As we know, Indonesia is categorized as a country with a high level of disaster risk. Yeah, nearly 75% of industrial infrastructure and basic connectivity in Indonesia include supporting facilities were built in disaster-prone zone. I want to ask, as a disaster nursing, what can we do in disaster management planning, and what kind of training can we teach to community people to reduce people health risk even when a disaster occur? Thank you.
Yeah, thank you very much. Yeah, in detail, I would like to discuss. Yeah, about in community management. Now we, for example, disaster nurse from the care perspective, join disaster management plan. Yeah, in the government, for example, or in also community. I go to a community area and just join and how to plan the yeah. For example, disaster management program and many communities they have, and health volunteer work. Yeah, for health volunteer work, and I train them how to make the first aid or shelter management, or yes, for example, this yeah already many management plan or training exist. But from the nursing perspective or caregiver perspective, we should join. So maybe many change occur. Like my presentation, everyone don't know. There are people want to know how to care or care insight or gender sensitive issue. So usually people don't know about this. So anyway, join and discuss and dialogue and uh, elaborate the disaster management plan for you and how and go ahead. I think I know in Indonesia many nurses join the many another discipline and sector another sector as not as a nurse but from the nurse perspective, for example, and the RM section and something. So and that anyway, the study together and initiate together. I think that's first step, I think.
Okay, so we must elaborate to our community people, right?
Yeah.
And bring our perspective.
Yes.
Yes.
Yeah,
Thank you.
I think that's the first step. So you can make own textbook or own initiative. I thought. I hope.
Okay. Okay. Thank you, Mrs. Sakiko.
Yeah. Thank you, Professor Sakiko, and thank you, Ms. Bidadari, for the questions. And the second questions will be from Ms. Trecia Sujana. Please, Ms. Trecia.
Thank you, Miss Stephanie. Hello, Prof. Sakiko Kanbara. How are you?
Yeah, long time
It's
no
so
see.
good to see you again.
Yeah.
Okay. Well, it's really interesting to hear your theory and presentations. As you know, in Indonesia, there are a lot of cultural aspects that influence health decisions of Indonesian people. What do you think about the people who don't want to move from the hazard? You said the first thing that they need to do is move from the hazard. But for the example from the Merapi eruption a few years ago in Yogyakarta, there's some people who doesn't want to go. They didn't want to leave their cattle and farms. And it's very difficult because the government and the health facilitator cannot really go there and risk their lives. And it's 100% their own choice to stay there and, just just ask God what gonna happen to them, and it's just they just didn't want to listen to the government. So what do you think about that? Because the government already like did all the things that they need to do, like they gave an early announcement of the eruption and etc.
Yeah.
Yeah.
Yeah, thank you very much. The good question. Or maybe I many time or same similar problem. We also in Japan many people don't want to move. Yeah, and furthermore about climate change issue and heat attack and many heat wave also and because elderly country they don't want to go hospital not so early. Yeah, and even though medical checkup very worse, very worse, and medical checkup, but they don't want to go to hospital and care, don't stay in community. Yeah, so yeah, I think and for that much more community as a talk and for beforehand as now and a talk community dialogue with the community and that make the solution together. Yeah, and to make yeah, start from, for example, family and how they want how to die, how to die or how to live on, and how what is your well-being and start from like topics, and they really understand. Oh, I don't want to. Uh, uh, they want to live on and escape of something, and how to make the early warning or how to collaborate with the community, and start from how they want to live on, and this kind of and I think this approach health volunteer can do that. I thought so. Collaborate with not and DRM section, but health as from health volunteer and much more proactive work we can do. So even though very and super strong and advanced early warning system from Japan or in Indonesia already they develop, but community people don't want to move. So yeah, that's why. So they let us discuss and with community people why they don't want to move. Something, yeah. So that's what must be one of result of the works, I think. Yeah, yeah. This is a global challenge, I think.
Yes, so it's a big homework for us, I think.
Yeah, and yeah, for example, this is one example of the example virtual reality and metaverse and yeah, nurse and community people and community kids make this imagination and image. They really need nursery and care child room in shelter. Yeah, before that, so far, DRM, especially for male DRM and stakeholder don't understand. Oh, nursery and kids room, they don't know need or not. Yeah, actually, definitely need. So, but not only talk to speak up, but visualize and like a nightingale, visualize and to let them know and they understand and negotiate also much more important. And also community people can understand how safe, how damage. Yeah, this kind of insight and put to them in, make the insight much more important, I think.
Okay, thank you so much, Professor.
Okay, thank you, Ms. Tricia. Yeah, Professor, there are questions from Ms. Patti Firtha from the chat. What lesson can be learned from the disaster experience in Japan that can be applied in Indonesia, especially for disaster nursings?
What?
Okay, maybe I will extend these questions. Your slides. How much is the risk? For example, in Bandung, we have a place that every years it will be a flood in there.
Ah, yes.
But
yeah.
But the community in there, they think it's not. I mean, it's for short tempers, for short periods. So they prefer to stay in there, even though it will happen every rainy seasons.
Yes. Yeah. So we focus much more climate change. Yeah, if you in the weather news, they newscaster say, "Oh, this weather, heavy rain. This is very coincidence. Once per 100 year every day." So every year once per 100 year occur nowadays. So yeah, now become worse and worse. And heat attack or number of heat attack is now big problem in Japan because weather is changing and changed. Typhoon is unexpected now. The typhoon and usually typhoon route is it's not change so much, but now very northern parts and affected to agriculture also now. So this kind of an unexpected disaster, including even though flood and weather, and of course, an earthquake many occurred. Yeah, and now in Japan and yeah, but not. I think in Indonesia much more. I think many biohazard bio infection disease. I know many. I know many. Yeah, so this kind of global discussion is very important because European country know much more environmental health issue, and African country much more another drought or another climate issue also. So this kind of, and in US, man-made disaster, they know much more and focus on much more. So this kind of global network and global discussion and much more merge and how what is that's a strong disaster analyzing that is important. So I mentioned about the culture at first.
Okay, Professor. There's one question from the chat from Miss Irma. She want to ask, how can we motivate health workers who working in primary health cares so they can continue or persistent in giving educations for global risk reductions. So how we can motivate them?
Yeah, this is and as I thought, I thought, and the global challenge, but local issue. So how, yeah, for start from what they want to eat. Yeah, and connect to global challenge issue. Yeah, so global issue, tone down, talk down what they want to eat, what they want to work, how to work, something like that. That's so easy communication and how this is just not an extreme issue, but everyday care. How to motivate for everyday care. So this kind of connection is very important, I think.
Thank you, Professor. So it's continue to working together and motivate together. So we have how to this one statement that I realize it's really interesting. Sometimes we focus on health of peoples, but the earth for sustainable coexistence, in my opinion, is quite, it's quite become less focused in my country, the sustainable coexistence. And can you give some suggestions for us to promote sustainable coexistence for our earth?
Yeah, sustainable, yeah. Yes, and so I think that is transdisciplinary and much more communication with not health sectors people, especially for more sustainability. And I think environmental scientists or usually we talk about interprofessional call medical person or DRM person, but now future or sustainability call and things existing. So much more not only environmental scientists, but also anthropologists, or for example. Yeah, usually anthropologist is very, very far from our works, but now we invite an anthropologist or much more architects and researcher also sometimes. Yeah, very, very new knowledge we can get and new solution. So this kind of action I recommend.
Thank you, Professor. Okay, maybe since the questions or discussion session is already done, once again, Professor Sakiko, before we close this session, if you have any closing statement for us. Okay, Professor, once again, thank you for invaluable contributions. And maybe you have any closing statement that you can give to us so we can enhance our motivations to global risk reductions. Yeah. Any closing statement, Professor?
Me?
Yes.
Terima kasih banyak. Yeah, I'm really happy. Yeah, because I work in Indonesia since 2000 was much when I was a student. Yeah, and first time I went to Solo 1999. Yes, so I have never been to Salatiga since 10 years ago. Maybe just visit Salatiga and collaborate with you and your collaboration, but after COVID, never been. So I ingin pergi ke Indonesia. So terima kasih.
Terima kasih, Professor. And we hope you can come to Indonesia back again. And we look forward to the possibility of future collaborations and your next conference in Kobe. I think in your presentations state that.
Please come, yes.
And future opportunities to learn from your expertise. Ladies and gentlemen, please join me in giving a warm round of applause for Professor Sakiko Kanbara for giving us some infallible knowledge. Thank you, professors. And I back to MC.
Thank you, Miss Stephanie, and also thank you, Professor Sakiko Kanbara, for your material for today. And at this time, as appreciation, we will give you a certificate for Professor Sakiko Kanbara and also for moderator Stephanie Melia. Please, operator, to display the certificate, and the certificate will be given by the Vice Rector of Immanuel Institute of Health, Dr. Antonius Ngadiran, SCUP Nurse, MCUP, MPD. Please, Dr. Antonius Ngadiran.
Thank you for Professor Sakiko Kanbara from Hoshi University, Japan. Thank you for your topic. I hope the knowledge is for our audience. Thank you. Arigato.
Thank you, Dr. Antonius Ngadiran. And once more, thank you, Professor Sakiko Kanbara, and for the moderator, Ms. Stephanie Melia. And this is the end of this session. So we can give applause once more for Professor Sakiko Kanbara.
Pak, hati-hati yo.
Bagi para pekerja keras yang berlomba dengan matahari pagi,
ya, badai dengan kategori 4 ini datang dengan angin.
Bojoku ngapa? Ada jaminan kecelakaan kerja. Buat yang banting tulang demi cita-cita yang tersayang. Ada jaminan hari tua.
Boleh jadi pilot nggak? Boleh, Dok. Pokoknya Ibu dukung.
Hati-hati, Pak.
Untuk yang memutar roda mengejar rezeki, nggak khawatir jalani hari. Ada jaminan kematian dan beasiswa 2 anak. BPJS Ketenagakerjaan agar mereka bisa kerja keras bebas cemas. Pasti aman, pasti cair, pasti tenang. Perlindungan pekerja sejahtera. BPJS Ketenagakerjaan.
Aku mahasiswa IKI dapat beasiswa BNI. Mau seperti aku, kuliah di IKI. Kalau kamu, bagaimana? Aku mahasiswa IKI, dapat beasiswa KKP. Mau seperti aku? Kuliah di IKI. Selain beasiswa BNI dan KKP, ada juga beasiswa lainnya loh. Untuk lebih jelasnya, mari bergabung di IKI. Kami tunggu ya.
Wave Beats Music.
Baik. Kamu tahu nggak apa itu? Di IKI ada banyak UKM tahu? Oh iya, mau tahu? Mau dong, ikutin lah. Nah, ini UKM-UKM-nya.